Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopaedic Society for Sports Medicine annual meeting in Denver, Colorado.
The AOSSM meeting is a premier sports meeting conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 8 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. Not all ACL techniques are created equal, and that's what makes Arthrex a global leader in the field of minimally invasive sports medicine. Arthrex continues to pave the way in the latest surgical technology for ACL injuries, a field they pioneered more than 40 years ago.
The Arthrex QuadLink ACL Reconstruction is the modern solution for ACL revision. With the Quad Pro tendon harvester, available in 4 sizes, surgeons can accommodate patients' unique needs using a minimally invasive technique.
The FiberTag Tightrope 2 simplifies graft preparation while delivering the best-in-class fixation strength. The first and only flat tape adjustable loop improves strength, feel, and handling. For LET fixation, the Arthrex Knee FiberTag Anchor provides a low-profile suture staple for strong, simple fixation that avoids the ACL femoral socket.
Visit arthrex.com and acltear.com to learn more about Arthrex knee preservation and the latest in ACL revision techniques.
Today's episode is going to focus on revision ACL reconstruction, starting with the diagnostic workup of a patient with a suspected ACL retear, as well as the surgical approach that follows, including graft choice, staging, the addition of other procedures such as LET and osteotomies. We are joined today by 2 outstanding guests.
Dr. Mary Mulcahey is a professor of orthopedic surgery at Loyola University's Chicago Stritch School of Medicine, Chief of Sports Medicine at Loyola University Medical Center, and Deputy Editor for Sports Medicine at the Journal of Bone and Joint Surgery. She is also a team physician for Loyola University Athletics and recently launched the new Women's Sports Medicine program at Loyola Medicine.
Dr. Clayton Nuelle is a professor of orthopedic surgery at the University of Missouri and associate editor for the Arthroscopy Journal. He's a team physician for Mizzou athletics and the head team physician for Mizzou football, soccer, swimming, tennis, and softball.
So, without further ado, let's go to the field house.
Mary and Clay, thank you so much for joining us for this special live episode of the Sports Docs podcast at the AOSSM annual meeting in Denver. We're so excited that you're here with us.
Awesome. Thanks so much for having us here. We're really excited.
Absolutely. Pleasure to be here.
Yeah, welcome. Okay, so on our show, we've spoken a lot about ACL surgery. It's probably one of our favorite topics, if not the most. In fact, Mary was our first guest ever, so over 3 years ago now?
Yes.
Yeah,
Which
so
is
we've been
crazy.
It is really crazy. So over 3 years ago now, we were just sort of reminiscing that we talked about ACL injuries, everything from patient selection all the way down to surgery to rehab. And then we also were just sharing that we also highlighted COVID return to play. So
Yes.
that's a little time capsule that hopefully we're not going to go back to.
Right, exactly. Never again.
So Mary, we want to start a little bit about, when you have a patient, we're not going to go deep dive into, diagnosis and everything, but we do want to have a little bit of a review refresh before we get into surgical techniques, which is going to be a lot of what we focus on today. With revisions. But let's start to talk about, the initial evaluation of a patient suspected of ACL re-injury, so after they've had surgery. So, Mary, if you've had a patient that's come in, you're concerned about an ACL re-tear after their prior reconstruction. So what are you looking for in the history? So not much, not getting into imaging yet or anything like that, but your history and exam, what are you looking for?
Yeah, so really important. I mean, I want to get all the details of what happened. Was there a specific traumatic event? Was the patient playing sports? Was it something at home? Was it a recreational activity? So really understanding what surrounded the event. Was it acute onset of pain? Did they immediately have that sense of instability? Did the knee swell up right away? And then how long ago was this, and what have been their symptoms since that happened? Has the pain and swelling gotten better? Have they just had a persistent sense of instability? And what types of things cause that sensation? So I want to get all of those details. And then, once I have a good picture of like what's been going on, then of course a very thorough physical exam is important. Just grossly evaluating the knee. Is it still really swollen? And then on exam, do they have pain with range of motion? What is the range of motion, right? Are they ranging like, only 20 or 30 degrees? Like that's terrible. Or do they have full range of motion? Like that's an important evaluation. And then, any joint line tenderness with concern for potential meniscal pathology. And then, of course, Lockman. And I don't typically do a pivot shift. I don't try to do a pivot shift in clinic. I think patients in general don't tolerate that well at all. So I would just evaluate them doing a Lockman. And I feel like most of the time they can tolerate that at least once. It just depends how acute it is. If the knee is still really swollen and painful, sometimes I feel like you can't even really get a good, accurate Lockman. So those would be the things that I would be looking at initially in evaluation.
Awesome. So after that fantastic history and physical exam, obviously we're going to get some imaging. And Clay, we know that one of the most important things in doing a successful revision ACL is identifying the cause of failure, making sure we don't repeat that, and then addressing that in our revision surgery. So after you do the exam and history, what imaging are you ordering, and what are you looking for on that imaging to guide your decision making?
Right. So, I think, after you have a pretty high suspicion or think that it's going to be an ACL retear, everyone pretty much almost unequivocally gets an MRI. We're all pretty familiar with that. But I think we all probably do a little bit more exhaustive imaging evaluation when it's a potential retear situation or potential revision situation. So in addition to an MRI, if there's significant tunnel widening or concern for tunnel widening, sometimes we'll do a CT scan. Sometimes you feel like you can gauge tunnel widening if that is occurring or that's occurred on an MRI, but sometimes a CT scan is helpful. And then I think alignment films, and then usually a full-length lateral tibia view to fully assess posterior tibial slope. And so I think, that's pretty much as soon as a patient comes in that's had a previous ACL and they got a swollen knee again, they're pretty much getting all of those studies, or at least maybe not the CT every time necessarily, but definitely an alignment film, definitely new AP lateral knee X-rays, and definitely a lateral lateral tibia, and then a new MRI.
Yeah, and as far as if you had an operator on this person, you might not have access to all their prior imaging, intraoperative. How important is it to get that?
Yeah, I think it's really important if you can. If the patient had surgery, you want to, know obviously when was it done previously? Was it local? Do they have the op note already randomly? I actually typically give my patients the op note. I like them to just have it. But so maybe they have the op note already, or maybe they can ask for it, but that's very helpful. And if they have their intraoperative, arthroscopic pictures, any and all of that information is very helpful to kind of guide decision making. And if they don't have it readily available, asking them if they can try to get any of that information will really help.
For sure.
Absolutely.
Yeah, sometimes it's hard, especially if you're at a tertiary center and you get a lot of referrals or you do a lot of revisions. Sometimes it can be hard to get some of that in smaller hospitals or if they come from really far away. Luckily, a lot of the implants we can typically identify and things, but sometimes we can't. Every now, at least probably once every few months, somebody comes in with an implant that I haven't seen in a really, really long time in their knee.
What is this? Post that on Twitter.
Yeah, exactly. Yeah,
Help
exactly.
me, please.
Basically, throw it out there to social media.
How do I get this out of there?
Yeah. How do I remove this, and do I need to remove it at once or in 2 stages? And so, I think the more information, certainly, especially in the revision setting, so we always kind of tell our residents and fellows, the more information, the better when you're talking about a revision.
Very true. I had one recently, or I guess it's probably a little over a year now, but she had her initial surgery in Thailand. She was in a moped sort of accident there, and it was a synthetic graft, and the femoral fixation was mid-shaft femur. And I was like, what is going on?
How'd that get there?
How did we do that?
I don't even know what instrument they used to get that there. Yeah. You see that every now and then, which is always entertaining for everybody in clinic, of course.
Right.
Entertaining when you're on the other side of the revision.
Yeah. But you're also like, well, what do I need to do? Or if it's completely out of place, then you're like, well, actually, it's not a problem because I can just drill my femoral tunnel and I don't even have to worry about that.
Yeah, for that, it was more just interesting. But certainly not a problem.
Exactly.
As far as, we've done all that initial workup, evaluation, imaging, and we're going to start to talk about surgery. So, Mary, we know you're a big fan of the quad. So laud the quad for
laud the quad, absolutely.
For both primary and revision ACL reconstruction. So talk us through the process of how you do select your graft, the initial graft you use, as well as, patient-specific factors that come into consideration.
So, yes, I do love the quad autograft. That's definitely my go-to graft for primary and revision setting. I guess it would be an interesting question, and maybe we can discuss collectively, but like whether maybe the patient had quad autograft for their primary surgery, and then what do you do in the revision setting? So I don't want to jump the gun, but just in terms of that, I mean, in general, that's going to be my go-to graft. That's definitely my favorite graft. Like that's what I've been doing predominantly over the past 6+ years. So that would be what I would go to. That would be my recommendation, unless there was some major reason why we couldn't do that. And what else? I mean, patient-specific factors, like, I think really, like, in terms of the patients that I'm taking care of most consistently, I just don't feel like any of those patients, whether soccer, basketball, volleyball, and, you know, high school, collegiate, almost professional or professional level, like, I wouldn't hesitate to use quad autograft in any of those patients. Yeah. Actually, in an ICL we did this morning, on a related topic, like one of the people that there in attendance was talking specifically about NFL players, and these huge guys and linemen and whatnot, and how maybe in that particular patient population there may be an issue with quad, like the quad atrophy or whatnot. I don't have any personal experience with that, so maybe in that particular patient population, I don't know, but I can't speak to that group. But in the patients that I'm taking care of, typically I feel very comfortable using quad autograft in either a primary or revision setting.
Yeah. So you brought up, we do want to bounce scenarios, because I always find that's really interesting when you're on a panel. It's like all three are used, or this is, you know, what you're going contralateral, what are you using? So Clay, I know you're also a fan of the quad, but what if quad is already used for the primary? What's your second choice in terms of that knee?
Yeah, so it's interesting. So I can just answer quickly. BTB typically, and a lot of people sometimes will ask, you hesitate to go to the extensor mechanism a second time or second hit phenomenon or something like that. And I'm not aware of any data that's shown like any long-term downstream effects. I mean, maybe we'll see it now that people are using quad and BTB a lot more. I don't know, but I don't think so. And so I don't hesitate to go to BTB if quad's been used before, or quad if BTB's been used before, vice versa. It's interesting because like I think the scope of my practice has changed a lot in the last decade. So like initially, you know, most of us trained on either hamstring or BTB for the most part, right? And so that was mostly what we did, or what I did, and a lot of us did. And then obviously over the last 4 or 5 years, a lot of people laud the quad, as many of us do on this panel, of course. And so quad's kind of become my primary, and then truthfully, BTB's become like my workhorse revision for a variety of different reasons. One of which being that I like the bone plugs if I'm doing it in a single stage, because I can take a pretty big bone plug and fill tunnels or fill bone deficits, and especially for a single stage revision. Or if you are going to do a tibial slope changing osteotomy, you're right there already potentially. You're opening up that front of the knee potentially anyway, depending on how you're doing it, or if you're doing that to change the posterior tibial slope. And so BTB, I do a lot more revisions now than I do primaries. And quad, I still like it for a revision too, because you can take a bone plug on one side if you want that too, or if you just want to do all soft tissue, or if it's a staged procedure, then I'll typically do quad. But it's maybe a little bit longer answer than just your scenario.
No, this is
like great.
This is why revisions are interesting. Like you really do have to think through all these things.
Different scenarios.
Actually, so we're in Denver. I practice in Denver. On the way in to the conference today, I actually snuck in a couple post-ops, and so the reason was he was a third timer. The first 2 were done out of state and done well. But he admittedly talked about how he went back to things non-compliantly very soon.
Yes. At least he was honest.
But he had quad. He had also had BTB. For many reasons, didn't want to do a hamstring. And he really was happy with the quad. So he wanted to have quad for his third. And so now we went and did the contralateral. So I did that on Tuesday. And the reason why I usually see everybody post-op day 1, but you start to think about, I really don't want you leaving the house post-op day 1 when you can barely like get around, and you have a nerve block on one side, you have a quad on the other side, and let me I'm going to sneak you in before my conference on Thursday so I can kind of see you for your dressing change. But, I think you have to work that's such a, you have to almost change your sort of protocol and your standard when you're going through these revisions. So it's okay, I'm going to go contralateral. That's going to change, how I prep in as far as setting up the room and where are we putting all the different equipment? What sterile drapes do I have? How are we prepping? Do I need more than one tourniquet? All the things. And then you're also changing their post-op visit. So there's just a lot of nuance. So we do want to go into the details.
Yeah, I think just making sure your team obviously is prepared for all of that. But piggybacking a little bit off of some of the things that Clay was saying, in the first few years of my practice, I was using predominantly hamstring autograft. Yeah. That's because that's what we did a lot in my fellowship too. Exactly. And as I started getting exposure to quad, I was very intrigued and just loved it. I mean, I loved how reproducible and reliable it is and how you can use it in a variety of settings. But that was kind of the evolution for me. And then I've tweaked my technique and modified things over the past several years. But I just think it's a fantastic graft, and it's been fun to kind of watch the evolution just within sports medicine in general.
Well, Mary, can you talk a little bit about how have you tweaked your technique? What have you learned? Share that.
Yeah, so it's a great question, and I think it's important we all go through sort of like growing pains, but just learning as we do more cases and as we just see how our patients do. But so in general, I mean, I use a vertical incision. I've always used a vertical incision. I now make that incision probably a little bit smaller. Like I think as I've become like more comfortable with like harvesting that graft. And I've modified my harvest technique a little bit. So I just use a standard 10 blade. I harvest it off of the proximal pole of the patella first, and I use the 10 blade to harvest probably about the distal 1 to 2 centimeters. I put a at the bond suture in the distal end of the graft, and I use that for traction. And then I actually will use METs to release the graft proximally. So I'll go on the medial and lateral aspects of the graft on the inferior and superior surfaces using the METs. So it makes it so I can release it proximally without actually seeing all of that. I'm just following the line that I've already created in the tendon. And then use the cigar cutter or whatever instrument you have from the company you're working with to release to actually harvest the graft completely from proximally. And in general, I do my best to like keep the capsule intact. So I'll harvest like the thickness of the tendon down to the capsule. With one exception, I'd say in like big male athletes, you don't need that whole graft because it becomes too thick. Yeah. So we did talk a little bit about this actually in our ICL this morning. But I think, aiming for between 9 and 10, I think in general we try not to have bigger than a 10 with a quad because it's a ton of collagen.
Yeah.
Absolutely.
Yeah, I would say another couple like tidbits that I learned over time was a lot of people would use that double blade. And initially I sort of was like, okay, I'll use the double blade just to kind of get my sizing. And then that went on back order, and so I use that Arthrex, the Quad Pro, and what I'll do is I'll open that out, take the, sort of the central slip out, and then I just take like a marking pen, and then just on that sharp side, I just put all the purple on there, and then I just make a little stamp. And that's sort of how I decide, okay, that's going to be my width. And then I've just found like it's just such a reliable way that it just like slides right in with the Quad Pro, and you just can pull that tension, and it is really reliable. But I just use that little stamp, and that's helped out a lot. I think that's a
great way. And one thing I didn't say specifically, but I will use, I think we all have like a little plastic ruler that comes in our sets, right? So I will cut that at 2 centimeters. Oh yeah. I put it on a hemostat. I have this all like ready before we even start harvesting. And then once I expose the quad tendon, then I take that little ruler on the hemostat and just mark out the central 10 millimeters of the tendon. Yeah. So I put marks, and I probably do make 3 or 4 of those marks, extending a little bit proximally. And then that's what I use for my 10 blade. I just go along the marks that I've created.
Yes, the Quad Pro's, Quad Pro is nice because it has a cutting edge, obviously, and then it also has tick marks for length, and so kind of where how deep you are. I mean, typical quad length is 7 to 8 centimeters, but you kind of know your depth if you're wanting to get something smaller, if you're doing a gymnast, for example, or you're doing a PD case or whatever, or if you're doing a big football player, like Mary said, and you want something a little bit longer to fill graft tunnels. And so it's nice to have that, like those measurements on the guide, and then obviously have the cutting too. I still use the double edge blade initially, mostly just to kind of score the tendon to see where I'm going up it and make sure like I'm going on track. Yeah, and so that you don't get too medial or too lateral. If you get medial, that's when you can get in the VMO and get bleeding. We could talk about tourniquet use or not, but so that's kind of keep you dead central or the 50-yard line, as we like to say.
And then do you do full thickness, or it just depends?
It just depends. Similar to like Mary said, I try and for sure leave the joint capsule intact, and then try and do partial thickness. But in reality, like in truth, it usually ends up being full thickness most of the time, and I don't have any qualms with that. There's been a couple studies that show no difference really, whether it's partial thickness or full thickness, and so it ends up being full thickness most of the time. But like she said, in some of the bigger patients, I've actually, early in practice, in football players, I would go, like shoot for like an 11 or something like that, and that's like now
a lot of collagen.
Now like my assistant's prepping it, I'm like, don't go above a 9.5. Like don't go above
I think like John Zerognius has had some good studies, X out of Emory, showing that like there's an increased risk of arthrofibrosis with a bigger graft too. So that I think definitely has helped us kind of modify a little bit the size.
But it's interesting in the this is a revision talk, right? And so people always think, oh, it's a revision, bigger is better or more is better. And that's not the case, obviously, right? And so it's about the technique, it's about the position, it's about the other factors that as to why the initial
rehab,
one
all of
failed.
it.
Yeah, exactly.
Yeah.
It's not because you need a bigger graft. That's not what you need
Yeah,
necessarily.
yeah. And then last thing, just because
Go
we were
ahead.
talking about technique too, the only other thing I've changed in that even recently in the past 3 or 4 months is that on the tibial side, instead of I had previously been securing the graft on the tibia with a biocomposite interference screw from Arthrix, which has worked great, and backing that up with a swivel lock. But I transitioned to using the small metal ABS button. And so I really like that. And I still tend to back it up with a swivel lock, although I don't think we absolutely have to. But I just sort of had gotten in the habit of that with the biocomposite interference screw.
Yeah.
Yeah.
May I ask? I have a couple of things to add about that harvest because
Yeah.
I've learned over the time. But I want to ask, why did you make the switch? I feel I do the biocomposite screw. I feel like I get good fixation, and then I back it up if I feel like it was too short of a graft. But why did you make the switch to the
Yeah,
button?
it's a great question. So I switched because I had a couple of cases where, I'd put the biocomposite interference screw in, and then I always go back in and look in the joint. And there are just a couple times where I'm like, it's just not as tight as I wanted it to be. And so I think we all think of like the theoretical risk of the biocomposite screw pushing the graft. I mean, I used that for years, for like 6-7 years. I use that all the time, and I was never worried about the patients or the quality of the the fixation. But just in a couple of those cases, it made me think like, maybe doing like the suspensory type fixation on the tibial side, then we can get that extra pull. And so I've liked it. But it did take some thought. I mean, I think as surgeons, we're all like kind of reluctant to change. But it was like, my primary like Arthrix rep and talking to one of my partners who also does this a lot and just thinking like, actually like this could be really good fixation. And once I started using it, I really like it. Yeah.
Yeah,
Yeah.
that's awesome. Yeah, I was just gonna say you were talking about you stamp it with the harvester.
Yeah.
So I remain too nervous to open that harvester until I confirm what size because despite me measuring, I do the 2 centimeters too. Despite me measuring, I'll cut. I don't know if it's just in my mind. I always want a thicker graft. Sometimes I need a larger harvester to harvest it. But something I started to do, which I think is especially good if you're using a small incision, is to cheat it laterally because I feel like if you pick dead center in the patella and you go, you're just gonna go right into VMO and get bleeding like you were talking about. And then someone taught me this spinal needle trick where you find that chiasm, you mark it with an X, but that can slide around, and so I put in a spinal needle and I know what direction I'm heading towards. And I feel like that can be really helpful. But I feel like, as you said, it progresses, right? Now you're using the ABS button, different harvesting techniques. I feel like we've really come a long way and will continue to. So I think it's a wonderful graft.
Well, the last tip that I think this is I think it was Rachel Frank who I heard say this, but if she goes full thickness and for closure, she uses the Scorpion.
Yeah.
So it's just like that fast pass, like back and forth. And I think, if you're trying to get up there with a needle driver,
Well, it does depend on how much exposure you have. I always close the harvest site too, but I tend to actually close just with like one ovicral or ovicral. I think if you get an Army Navy in there, you can usually see. But bottom line, I think that it makes sense to me to close the harvest site.
Two quick tips that'll help with that, and you guys probably do it too.
Yeah.
So even if you use a small incision, which I think we all probably do at this stage, I'm pretty aggressive at resecting the bursa, the bursal layer on top, so you can really visualize the whole quad, just like Ashley was saying, that kind of whole distal quad, so you can kind of see those layers. And then for closure, I actually use a barb suture. And I use a barb suture on a UR6 needle, which is this tightly curved, small but very stout needle. And so you basically just go right down the line to close the harvest site. To close the harvest site. And so I've done it with the Scorpion, but then you put the camera in there and look up there, and it's you're kind of going back and forth, which works fine. But literally with the barb suture, most of you probably used it maybe in other applications and remember it for arthroplasty applications, closing arthrotomies, right? You just bang, 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 right down the line. So.
Yeah.
Great.
That's awesome.
So it's little good tidbits.
Yeah, exactly. Awesome. Well, that was a really good discussion on the different graft choices. So now let's talk about our approach, specifically one stage versus 2 stage. So Clay, how are you deciding between 1 stage and 2 stage? Is that a pre-op decision? Do you tell every patient I could have to do a 2 stage when we get in there? What's that discussion you're having with the patient? Yeah,
so that's a good one. That is almost invariably a pre-op decision based on kind of all the factors of all the things we already mentioned in terms of the evaluation. So are we going to have to potentially change the slope or do a slope-reducing osteotomy? Are the tunnels really big and we're going to have to bone graft the tunnels, which you can do in single stage depending on how you do it or depending on your technique. But oftentimes for me, if I'm going to bone graft tunnels, it's going to probably be a 2-stage procedure. Is there concomitant stuff that needs to happen? Like, are they going to need a meniscus transplant? Are they going to need cartilage work? Are they going to need an osteochondral allograft potentially because they've got a huge cartilage defect somewhere now, or something along those lines? And so obviously that'll be potentially a 2-stage. And so I think it's almost invariably a preoperative decision based on what else they need or what they're going to need to get to the final fixation.
And We'll ask both of you, as far as that tibial tunnel osteolysis, what are your parameters that you say, this is a one stage, I'm going to just take a bone block and feel like I can fill that, versus like, no, we really have to bone graft this separately. And then also, it's fun to have the visitors. Also, what are you using for your bone graft?
So I agree with everything that Clay was saying about decision one stage versus two stage. I think thankfully more often than not we can do one stage, but we definitely are evaluating all these parameters, and if there's a lot of other work that has to be done with regard to cartilage or osteotomies or whatnot, like we are very frequently doing a two-stage procedure. In terms of the tunnel widening, so I think tibial and femoral side, like we're looking at that. Of course, we're evaluating initially on the pre-op x-rays, and then if we feel like we can't get a good sense of really how wide that is, getting a CT, absolutely, getting back to one of Clay's earlier points, to really evaluate that diameter. So I think it's somewhere between, it's like above 12, probably, like we're really considering doing a two-stage procedure. And we have a lot of different options in terms of like bone grafting. Thankfully, like we can, for the most part, have pretty easy access to like the bone dowels, and so using those, like that's been great because you can get them different sizes and they're fairly easy to insert. So that's kind of my like cutoff and my thought with regard to that.
Yeah, it just depends on what study you quote. You know, there's a number of different studies out there. Some that'll say 12 millimeters is a cutoff, and some will say 14. Yeah, and so I think everybody, that's kind of the general gestalt for all of us, right? And one of the things that's interesting that I look for though is, those studies generally quote it like that measurement at the aperture, which of course is probably maybe the most important in terms of depending on what kind of fixation you're thinking about for your revision and things like that. But in some of the revisions or some of the grafts, they get the windshield wiper effect, right? And so you get that tunnel, like you were talking about, Catherine. You get that lysis below it, and like within the the cancellous bone or even below the aperture and stuff. And so it's actually wider than maybe even what you measure at the aperture. And so I think you have to take that into account. And some people talk about bone grafting those ones, that maybe are on the cusp at like 12 millimeters at the aperture, but they have the windshield wiper effect below it and wider. Bone grafting those, but still doing a single stage procedure, through a bone graft, especially if you're using something solid like the Arthrex bone dowels, which some people, and I've done a couple times in the single stage, put the bone dowels in and then drill through them.
Same.
Yeah.
But not huge lesion.
No, it can't be really big. Yeah, because then the graft is unstable. Then the graft potentially, you worry about stability of the graft, and then the bone. And so, but those are truthfully those are my go-to for even if I'm going to stage it and do bone grafts, because they come in all different sizes, right?
Yeah, it's really nice.
Really, you just ream up until you get the healthy bleeding native bone, and then you press fit the bone dowels in there to whatever you reamed up to, and so they're really easy to use, and so that's definitely been my go-to bone graft.
Yeah, I think it does make it a lot easier. And I was just going to add that with the single stage, I think sometimes it's like, it's even a position of the tunnel. Maybe it's only like slightly wide, but maybe that tunnel is a little too anterior, a little too like posterior, and you're just like, I just want a different sweet spot there. But if I can sort of stack, like that bone dowel there and then drill, and maybe you're drilling through like half of that dowel or something like that, but you're getting the position you want.
Yeah, and then I think another question, if you are planning to then do a two-stage procedure, is thinking about, okay, well, when are we coming back for that second stage? And I think there is some variability in the literature too, but in general, there's kind of like more towards like the 6-month time frame, right? I'd say it's probably no sooner than 3 months, but probably leaning more towards 6 months. I don't know if you guys think any different.
Absolutely, around 6 months. And I think it depends on what you're going back to, but if you're waiting for bone graft to heal in and things like that, I think that's really the number you're aiming for.
Yeah, I think some of it depends on how stable you feel like those dowels are and stuff. I mean, we know they take at least probably 6 months to incorporate, and sometimes longer. In some cases, I've gotten like a CT scan at 4 months or so, and if they look like they're pretty well incorporated or pretty solid, then I'll go ahead and go, and I've gone back in, and it's amazing like how it looks pretty well like a native native knee when you as we've all seen when you go back in and do that. And then I haven't seen any issues with that, and so I've gone a little bit earlier, even though certainly I think like if you want full incorporation in 6 months or even more potentially is the way to go. So like Ashley said, it kind of maybe depends on the patient and the situation, but
If you're looking for a trusted name in allograft transplantation and want to learn more about your allograft options, then look no further than JRF Ortho.
JRF Ortho is an innovative leader providing the widest array of pre-sutured tendons, including the only BTB pre-sutured tendon on the market. Plus, they are the first to offer OCA cores available in 10 millimeter, 12 millimeter, and 16 millimeter sizes for small focal osteochondral defects.
JRF Ortho also prides itself on superior customer care, making your ordering process JRF Ortho easy. They are committed to accommodating your needs, usually delivering an osteochondral allograft around 30 days, all on your terms. So if you're tired of waiting weeks for a condyle or waiting on a back-ordered tendon, reach out to JRF Ortho to find out how you can get your allografts in a timely manner.
And the most amazing thing is that JRF Ortho aims to give you one less thing to think about, so you can just focus on what matters most, your patients.
So discover the only allograft company focused solely on sports medicine. Order your allografts today with JRF Ortho. So now let's talk about some surgical additions to decrease the rate of a repeat revision surgery, right? So there are some things we want to talk about, osteotomies, but we're going to start with lateral stabilizing procedures. So Mary, can you talk us through your indications to add a lateral stabilizing procedure? And if you're doing that, are you doing an LET or an ALL or something else?
Yeah, so this is a great topic, and it's really something that's been interesting to watch this evolve over the past several years. Like, it's been a huge change and alteration in our technique and how we approach just ACL reconstruction in general, but certainly in the revision setting. So yes, I do an LET, so the lateral extra-articular tenodesis in a revision setting. I have not done ALL reconstruction, but I think the literature shows that you could really do either of them, but I think doing some type of lateral-sided procedure in a revision setting is really necessary at this point, and there's great evidence in the literature to support that. So yeah, in every revision I will do that, and I do a modified Lemare technique, and we've seen some great presentations already here the first day at AOSSM talking about that. So I think there's so many different ways you can secure the graft on the femur. You could use an anchor. You could use a like biocomposite anchor. You could use a PEEK anchor. You could use an all soft tissue anchor. Like, I've transitioned to using an all soft tissue anchor because it's tiny and you just have to worry about it less with regards to the femoral tunnel for the ACL.
Absolutely.
Which I have absolutely loved that transition.
Yes.
So yes, that is, so for me now, my main indication for LET is revision setting. I think we're seeing more and more like support for doing it in the primary setting in very high risk patients. So super young, very high risk sports, hyperlax female. So I think that those are really reasonable indications. And then also using hamstring autograft in a primary setting with Stability 1, I think that's tremendous evidence to say that if you're doing hamstring in a primary setting, like, you really should be adding an LET.
Absolutely.
So I think she hit the nail on the head with all those types of things. I think I'm adding either some sort of a lateral augmentation, either ALL or LET, and or some sort of internal suture augmentation to almost virtually every revision, one or the other, or in some cases both. And I think the only ones where I'm really not doing some sort of augmentation is a patient where it's like was gross tunnel malposition, and I think that is the sole reason that the ACL failed, which we see a fair amount. I mean, right, that's the number one reason for ACL failure, right? Tunnel malposition with the primary surgery. So we see that, but I think truthfully, in the majority of revisions, I'm going to do some sort of lateral augmentation. I like LET as well, and do like a modified Lemare. I like Arthrex's knotless fiber tack. It's really slick, just like Mary pointed out, really easy to use, really low profile. ALL, if the patient has had something done to the IT band before, or if it's a multi-lig and I'm already kind of wide open and stuff, and maybe the IT band's been injured or the biceps has been injured in a multi-lig setting or something too, then that's when I tend to go to an ALL, just because I don't think maybe the IT band's been disrupted in some way, right, and the fibers aren't maybe as stable as they once were. So that's kind of my primary indication for an ALL. I mean, you can use either one. People, use both. Obviously, the Santee group had a big trial looking at both of them, and the results are essentially equivalent between ALL and LET. And so I think you can use either one of them. But yeah, certainly the revision setting, I'm using it most of the time.
Yeah, I agree. And I think we talked about it a little bit earlier as far as when we got all of our imaging study, as far as like looking at alignment. And you mentioned tibial slope. As far as tackling an osteotomy, whether, whatever type it is that's indicated, how do you stack that all in your planning?
I'll let Clay talk about
Okay.
that.
Yeah,
I've
sure.
not really
So-
embraced that yet,
It's
being
okay.
honest.
Yeah, I love osteotomies. So
So go, Clay.
Yeah, no. So that's a great question. And obviously that's becoming more and more in vogue. We'll hear a lot about it, over the next few days here at the meeting, of course, and slope changing osteotomies and things like that. So I think, so for me still, I've only done a couple where in like a primary revision, so it's usually a staged procedure. So I'll usually do an osteotomy and then kind of clean up a lot of things and then come back and try and make it more like a primary ACL, because that ends up being a lot of recovery. And certainly when you have the osteotomy, you may limit weight bearing for a period of time and things like that. Whereas with a normal ACL, even a revision, like I don't want to do that if I don't have to, right? And so, but there, and then there's some different things out there. That there's some different types of techniques and some guides and stuff where you can drill cross guides or drill across the osteotomy and still do your ACL concurrently in a single stage, which is good too. And then you can talk about different types of techniques for slope changing osteotomy, super tubercle, at the tubercle, below the tubercle, take off the tubercle, different types of ways that you can do it and stuff. And in Europe, they do it all different types of ways. For me, I've typically gone super tubercle because you can kind of basically aim kind of right back there, and then you utilize staples for fixation. But like I said, oftentimes it's in a stage setting. And then if you want a bone graft, tunnels at the same time, then that works great, right? And then you come back once the osteotomy's healed and the tunnels have healed and the bone graft's healed, and then it's like a primary ACL.
Do you find that they always come back?
I mean,
I think that's a
yeah, it's a tough one, right? Because especially
Feel
because
stable.
yeah, right. Yeah, they feel stable, or some of that patient population may be like a working population, right? Like
It's a lot.
it's not our 16-year-old female soccer player typically. It's like a older working population, and so they say, I'm not going to come back and have another major
good.
surgery.
Yeah, exactly.
Yeah. So it's a great point for sure.
And
Yeah,
I'm sorry,
no,
Ashley.
go
I
ahead,
was just
Mary.
going to add to that. So, I think we have seen a lot. We talk a lot about what may even be the indication in terms of like what slope should we be thinking about
That
this.
was my question.
Yeah. So I think we've seen pretty conclusively that with posterior tibial slope and even maybe lateral posterior tibial slope more specifically of 12 degrees or greater, like we should be thinking about this.
Yeah.
But I think really like the next question, and I don't know that we have the answer to this, is should we be considering doing this in a primary setting? And I think that that's sort of scary for us as sports surgeons to say, okay, we're going to do an osteotomy in a primary ACL.
Well, scary for the patient.
It's scary for
it's
them.
a lot.
Exactly, but scary for us to like bring it up to them and for the patients
Yeah.
to consider.
Yeah.
Wait, like I've had friends who've had an ACL reconstruction. They didn't talk anything about their bones. So I think that we're going to be hearing more and more about that. And I know there are probably some surgeons, I don't know so much about in the U.S., but probably in Europe, that are doing that slope-changing osteotomy in a primary setting. I think we just have to be aware of it. We have to be cognizant, be evaluating it, and certainly in a revision setting, which is what we're focusing on here, really be evaluating for
The
that.
primary is definitely a big jump, especially depending on the patient. I mean, I think for some people, even just adding like a lateral augmentation is a jump in the primary setting, right? I mean, maybe some of us aren't even doing it all the time. I'm not doing a lateral augmentation in every primary ACL.
Only high risk.
Yeah, right, exactly. And so talking about doing an osteotomy is a pretty big jump, especially if you're talking about like an athlete, like most of us treat, right? And so I don't know that we'll get there too quickly, but
I
certainly,
hope
like
not.
you said, but the revision setting is what we're talking about, and so it's definitely got to be a consideration, and along with all the other factors.
Now, we kind of had talked about when to add an LET versus a slope-reducing osteotomy. So there's a lot of talk out there, don't do an osteotomy. If it's a slightly elevated posterior tibial slope, an LET or some lateral procedure should be enough, and there's papers to support that. So you had said 12. Do you have a number, or are there patient factors that would maybe push you away? This person's an athlete, I want to stay away from an osteotomy. Like, how do you make that decision if that posterior tibial slope is borderline? Maybe to both of you guys.
Yeah, so I mean, I think interestingly, sometimes, some of the indications people talk about for an LET is like hypermobility, hyperlaxity, right? Hyperextension, high grade pivot shift, all the things we all know. But then sometimes, if they have a lot of hyperextension or hyperlaxity and they have a really big posterior tibial slope, like that gets really risky, right?
Yeah.
And so I think those are the toughest ones, because you're certainly right. Like there's people that have talked about saying, well, posterior tibial slope doesn't matter if you're adding a lateral augmentation and you're adding internal suture augmentation and you're throwing the kitchen sink at them with everything but an osteotomy, right? You have pretty good chances or whatever, and that may be true, and that may bear out in most cases. But certainly that really, really high risk patient, you kind of have to wonder and kind of have to think about. And so I think those, as we've been talking about throughout all this, the specific patient factors are what kind of push you one way or the other. As I stated already, for most revisions, I'm at least doing lateral augmentation and sometimes a little bit more. And then obviously, I think for me, for posterior tibial slope, if it's getting more up into like the 15, 16, 17 range, then that's when I'm going to say, all right, this probably needs to be done. And obviously, I know the literature says 12, but like, I think we all see a fair amount of patients that are at like 11, 12, 13, and you're like, that's a big operation for,
Exactly.
So I think I push that limit a little bit more maybe.
Yeah. And I think like all things, and people will say this with LET too, like, we don't want to swing all the way. Just like make sure we're not sort of seeing that it's indicated everywhere, and just, being cautious before the needle moves too far and then we realize we've totally overdone it.
But it's very interesting because in the opening ceremony this morning, or the opening ceremony went into the first didactic, and there were people up there advocating for an LET in anyone who was like under the age of 30 or under the age of 25.
Yeah.
And I was like, I mean, sure, yeah, I guess it would decrease the rate of graft rupture, but at what cost, right? Do we know in terms of data on over-constraint? Do we know the impact on the lateral compartment? And you're right, before we throw it at everyone, I think we have to really clarify our indications and see the long-term data regarding it.
Yeah,
Yeah.
No, I think so too.
All right. Well, I think we're going to wrap up our conversation on another one of our favorite topics, which is recovery. So obviously, you can't treat, primary ACLs and revision ACL, and so if we're just thinking about straightforward like revision ACL, don't worry about we're doing osteotomies and all this sort of stuff yet. Do you change your rehab protocol? Do you speak to your patients about return to sport differently? Like, how do you talk about those the recovery process for a revision ACL, Clay?
Yeah, so I mean, again, a lot of it depends on what else you're doing. Most oftentimes in revision, it's more likely there's going to be meniscal pathology, right, or chondral or whatever else, just like we've been saying this whole time. And so sometimes that's probably going to dictate it more than other. If it's truly just a straight ACL revision with lateral augmentation, let's say, for whatever, then I don't really change my rehab at all. Now, I still do tell them, like, it's going to be long.
Yeah.
Like most of those athletes, I tell them a year.
Yeah.
Whereas maybe primaries, I tell them 8 to 9 months
Yeah.
in general, or something along those lines, again, depending on the patient. So I kind of try and set those expectations and maybe set them out a little bit further, as you were alluding to. But if it's truly just an isolated revision primary, especially single stage, then I don't change the rehab really much at all in that setting.
Yeah, I don't change the post-op rehab either, but I think the counseling and the discussion you have with the patient beforehand is really important, just about expectations in terms of, the immediate post-op period, what they're going to be going through, and return to sport, and that overall the outcomes are not as good as primary, the primary ACL reconstruction, just to help them understand. Like, obviously you're their biggest cheerleader, like, encouraging them and supporting them to get back to whatever they want to, but just helping them understand that it's a different situation, it's more complicated.
Yeah, I think that second hit phenomena is just real, that, even just muscle recovery, at the most basic level, it's a second hit. It just doesn't always bounce back as fast. And, I think the other thing we always have to be mindful of is just that psychological sort of response is different too.
Yes. Oh, yeah.
Well, especially if it's an early
It's
revision,
huge.
right? Like if it's a revision still within that 2-year point, and especially if it's an athlete, you're totally spot on with both of those things, both physical and psychological hits. It's going to be hard. It's going to be way harder than what the first one was from a recovery standpoint, because of that all the things you just mentioned. And so.
Yeah, and in that situation, that may be one where right from the beginning, where I would be encouraging the patient and or the family, depending on the age of the patient, to really be working with a sports psychologist. To just say, it's a challenging issue to be going through. This will be hugely helpful to you to have this support. And then I also always encourage them, be present, whatever it is. If they were playing soccer or they were playing basketball, to still be present, to still try to be engaged with their team, because still that helps them mentally and socially. Exactly, helps them recover more from the injury and the surgery. So, but I think that's important.
It sounds isolating.
Yeah.
That's the hardest thing. And it was with COVID, it came remote learning, right? And they still have that option. So a lot of my surgical patients would be like, well, I'll just do remote learning until, for weeks and weeks and weeks. And I said, no, you have to go back to school. You have to see your friends. You have to see your team. And that the people that stayed at home were the ones I found struggled the most with the post-operative kind of psychological aspects of it. You have to get back to your norm, and it's part of the recovery.
And I think even just managing like we've discussed their expectations, but just the time spent with them and stuff, right? So the 2 patients in my clinic that my assistant will oftentimes say, you're going to need a little bit more time, or we're not going to see you for a little bit, or the complex patellofemoral patient and the revision ACL patient, particularly in a teenager, right? That comes up on her schedule. She's like, oh man, we're going to be behind this afternoon.
Let's just be ready for it.
You're going to be in there for at least half an hour. And so, and I think we all know that, but it can't be stressed enough that to your point, Catherine, that psychological component has to be managed, and the expectations have to be set from the outset, and that takes time sometimes.
It's hard. Yeah, and I think it's there's that early sort of loss that they feel. It's a little loss of question of identity. If I'm not that, what am I? And then if they do get back, then it's all the fear. The fear of re-injury.
Which is even higher than they're going through it the second time around. But I think, we're seeing these patients maybe once a month, whatever, 4 to 6 weeks. But it's still an opportunity for us to be checking in with them, and not just how's PT? Oh yeah, let's look at your range of motion. But how are you doing mentally with this? Are you thinking? Do you find yourself thinking about your knee less? Are you more confident? Just kind of gauging that. I think is helpful for them too, and they realize that we care about how they're recovering in that respect too, and not just the physical side.
Well, and if you saw the other thing we incorporated into our clinic, if you saw Dr. Albright's study, who's at Colorado Children's on grit, and how it's like so closely tied. So it's like, we'll look at those. Not that we always know what to do if they have a lower grit score, but it at least sort of sets like, okay, got to pay attention to that one.
Yeah.
You know, that it's just, you know, they might need a little extra. Like
Yeah,
maybe
and-
the follow-ups are closer together. Maybe the, you know.
Yeah, a little extra TLC,
Yeah.
but I think that's one of the newest
Yeah.
factor that's been identified that clearly has shown an association
Yeah.
with recovery.
Absolutely.
Yeah.
Awesome. Well, thank you both so much for
Yeah,
joining us
you
here
guys are
today.
the
This was an
best.
awesome discussion, and so happy you both decided to join us again because
Again.
you've both
Yeah.
been
Yeah.
on our show. So enjoy the rest of your meeting, and thank you again.
Yeah, and we should give a shout out to your past, because we talked about Mary's past episode, but
Oh,
Clay also did a
yes.
two-parter on cartilage. That was pretty
Whoa.
awesome.
Yes.
Yeah,
Nice.
it was
Yeah.
awesome.
Yeah.
Yes. You guys have the
fun.
heavy hitting topics. We
That's
put you
good.
on.
Yeah.
That's awesome. Well, you guys are doing awesome with this.
Yeah.
Obviously, you've taken this to like a whole nother level,
Oh,
which
thank
is
you.
We're
Awesome.
having a lot of
so
fun.
Yeah,
But no, thank
congratulations.
you. You
Thank
guys are
you.
great guests, and
Yeah.
I promise that we get a lot of feedback on different episodes, and everybody loves like how you can distill information in a way that makes it very available to people and not intimidating.
Yes.
And so great job for you guys.
Thank
Well,
you.
thank you and
Yeah.
congratulations. Thanks so
Yeah.
much for having us here today. It's a lot of fun.
yeah,
course. Thanks.
absolutely. Thank you guys.
Bye.
Thank you for listening to this episode of the Sports Docs podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love hearing from you.